Okay, so thank God my dog saved me from the mailman. So I'm back. One thing you want to tell your patients is that any drugs for the respiratory system can only be helped by drinking plenty of fluids. And some places say 2 liters, some places say 2 quarts, but they're basically the same. I think 1 liter is 1.06 quarts, so pretty much the same thing. If you drink 2 liters of non-dehydrating fluids a day during times when you're taking respiratory meds, they will help break up that mucus and thin it out so that it can be more easily coughed up. Notice this information's in red, just saying. You don't want to drink caffeine like soft drinks and coffee because that's going to dry things out further. It's dehydrating. So you want to drink water, you want to drink juices. Milk tends to cause problems with mucus creation, and so that's not necessarily going to be helpful. So if you drink milk products or caffeine products, just make sure you alternate with plenty of non-dehydrating liquids. There are lifespan considerations that need to be considered on page 110. For pediatric patients, remember that anticholinergics do not go well with children. Those sympathetic nervous system reactions can be really hard on children. They don't need their blood pressure and their heart rate going up like that. Children also have what are known as paradoxical reactions, where these drugs are going to work the opposite. Maybe they will sedate you, but they are going to drive your young child wild. So while you're all sleepy because you have an upper respiratory infection and you just want some rest, your child is bouncing off the walls and not letting you rest. Elderly people, studies are showing more and more that they should avoid anticholinergics. They are more likely to get orthostatic hypotension. They're going to get dizziness. They could faint, and that's going to increase all around their falls risk. They sometimes can get extrapyramidal reactions like we talked about when we talked about the central nervous system medications. It works on the part of their brain, so they can have some of those side effects we talked about, the tardive dyskinesia. They can have weird, unusual movements of the head and the mouth. They can have repetitive muscle twitches and body reactions where maybe they are restless, they can't sit still, muscles twitch when they're not supposed to. They can also get confused, so that can be difficult to tell sometimes. Is this confusion that my loved one has, is it because of their illness, or is it because of the medication they're taking, or are they really, getting dementia? Memory can be impaired. So if this is a person who does not have dementia, that can be very scary for their family members. It's like all of a sudden, Granny can't remember what's going on. You're never really sure how these anticholinergics are going to work on an elderly person. Some of them, it can really raise their blood pressure, dangerously so. Other times they can have bad hypotension, which increases cardiovascular responses and falls risk. So anymore, a lot of times they're saying, don't even give anticholinergic drugs to the elderly. Doctors will still order them. Grandma's got a upper respiratory infection, give her some Benadryl. And then when, grandma just goes, temporarily off her rocker, they don't want to admit that it's the Benadryl that did it, but sometimes it can be. The next category of med we're going to talk about is a fairly new med as these things go. They've been around for 15 or 20 years, but they're still fairly new compared to other stuff. And these are the leukotriene inhibitors. Cysteine leukotrienes are other inflammatory chemicals that are produced when the immune system is overstimulated. And these inhibitors can block those receptors. These leukotrienes don't even have names. They have numbers and letters. But they can block those receptors and so control a lot of those problems like histamine causes, the vasodilation, the capillary leakage, edema in the surrounding areas. The inhibiting the leukotrienes can help with that too. So these meds work really well for asthmatic patients who maybe can't tolerate steroids. And they work for nasal congestion too, kind of long-term treatment. Our prototype drug is montelukast or Singulair. We also have Accolate and Zyflo, but probably Singulair is going to be the one that we see most often. So people who can't or won't take steroids many times are helped by this. It's a tablet, a PO med, usually in dosages of 4 to 10 milligrams. It's recommended that people take this on an empty stomach and that they be educated that this will not work on acute asthma attacks. So if you are maybe on a hayride and all of a sudden the hay gets you wheezing and you can't breathe, popping a Singulair is not going to help. You need your rescue inhaler. So patients need to be told to take their Singulair every day, but also keep their rescue inhaler handy. It can cause nausea, and sometimes people report that they have increased headaches. Usually they will get used to the med and the headaches will stop. And if they take the med with plenty of water, the nausea should get better. Make sure you read Patient and Family Teaching on page 111 for the leukotriene inhibitors. They're really, really, good meds for the ones who take them as directed. On page 112, we see a med for asthma prophylaxis, asthma and allergy prophylaxis. In the text, it's discussed on page 112, and then in the table, they talk about it on page 110. But these are the mast cell stabilizers, also known as the chromones. Mast cells are cells that are all through the body, and mast cells are very touchy. They're very fragile. They're going to bust. They're like, little delicate balloons. They're going to bust at the first sign of an inflammatory reaction. I kind of can compare these to like your really hyper excitable aunt who, is just anxious about everything and, every little thing she busts out crying. Well, she's like the mast cell stabilizer of the family. Any kind of a hint of a foreign invader and an allergic reaction, these mast cells rupture. And they're going to release histamine, they're going to release those cystinyl leukotrienes, and some substances that are involved in anaphylaxis. And so what we need to do are to keep these meds available all the time. They work as a preventative for asthma and allergies. They're not going to work for acute symptoms. So if you have an allergic reaction, you can't just start using your inhaler, your Chromalin inhaler. It's not going to work. It's for prophylaxis only. But what it does is it helps stabilize the surface of the mast cells so they don't break or rupture quite as easily. I compare them to, like a weighted blanket pulled over, a nervous person. It just kind of calms everything down and helps them relax and not rupture at the first sight of any problem. Our prototype med is Chromalin sodium or Intol. You'll also see Netochromyl sodium. And these work not only for asthma, but also for allergic rhinitis, that allergy-related rash that you see with eczema, chronic hives, somebody who has a lot of hives and reacts to substances around them, and then bronchospasms that just come on from things like cold and exercise. So once again, the person has to take these every single day. They're not going to be a good rescue inhaler.